Hello, everyone. Apologies, I got a meeting to say, sorry, I got a notification to say the meeting had ended, to my surprise. So, apologies. I think that might have been the same for everyone because I can see some people trickling back in. So, Catherine, apologies. You were very rudely cut off. So, I'm just going to remake you a panelist so you can jump back in. I'm going to do the same for Sarah as well. Bear with me. Catherine, can you hear me?
Yes, I can hear you.
Wonderful. Sarah's just joining back as well. So I'm ever so sorry, everyone. It wouldn't be technology if there wasn't a blip in the system. Despite Catherine, Sarah, and I jumping on 10 minutes before to make sure there was no teething problems. Mid-flow, we've experienced a teething problem. So I'm going to stop talking. Stop sharing my video. I'm going to reshare the screen. Catherine, I'm just going to ask you to give me a yes if you can see the screen, and we're ready to go once you're ready.
Danny,
Yeah,
are you able to put my camera on?
Yeah,
oh yeah, same
sure,
for me, please.
of course. Sarah, Catherine, that should come through for you now.
Oh yeah, there we go.
Wonderful, great stuff.
Hopefully I'm back on.
Apologies again, everyone. Thank you for your patience. Right,
Okay.
Catherine, over to you.
So we were just
As you were
beginning.
saying.
So just talking about the average age for the menopause, and then this concept of the perimenopause, which is the time around the menopause. We tend to use the words interchangeably between perimenopause and menopause. The perimenopause usually lasts between 2 and 7 years. It can last longer. And as the average age is 51, the perimenopause can begin before that. So some women can start to experience symptoms in their 40s. Now, the proper definition of the menopause is the stopping of your period. So it's literally the pause of menstruation, hence the name. But you can only really diagnose actual menopause in retrospect, because you don't know that your last period is your last period until a year goes by without one. And there's obviously a whole lot more to it than just your period stopping. But that is what the word means. So perimenopause in some ways is more helpful because that's the time leading up to it. So during that time, coming up to the menopause, the ovaries produce less estrogen. Now, estrogen is a really important hormone, does loads of things, lots of different bodily processes. It's a really important player in women's lives, and it probably does even more than we realize. There's still new research going into what estrogen does. Now, throughout your normal cycle, the hormones vary naturally, and women tend to get to know their own pattern. But in the menopause and perimenopause, the estrogen levels stop having this pattern and can start to rise and fall quite sporadically, which can lead to these erratic hormonal changes. If we have a look at the graph that comes up on the next slide, so that shows these fluctuating levels of estrogen. So during the reproductive years, you've got a nice pattern, and then in the perimenopause, the estrogen is all over the place before it really drops off in the postmenopausal period. Now, estrogen, as we said, is a great hormone. Fluctuating levels of estrogen is not such a good thing and can lead to a myriad of different symptoms. So if we just look at the next slide, the symptoms we can put into 3 categories. So we've got physical symptoms, psychological symptoms, and gynecological symptoms. And all of these symptoms are to do with the lower or fluctuating levels of estrogen. So some of the physical symptoms are hot flushes. Oh, sorry, back one. Hot flushes, night sweats, skin and hair changes, weight gain, aches and pains, and heart palpitations. Some of these psychological changes are mood changes, brain fog, just kind of a feeling of confusion, not finding the right words. Women experience tiredness, lack of energy, insomnia, and anxiety. And then the gynecological changes, which are vaginal dryness, low libido, painful sex, urinary problems such as incontinence, irregular periods, very heavy periods, prolapse. So it's quite a list. The list goes on. And these symptoms can happen in any order. Some women get lots of them. Some women get very few symptoms. And some women actually barely notice the menopause. And that's okay too. It's good to be informed, but it's not necessarily something to be seeking. Now, the other thing about menopause is there's all these symptoms happening, and it's usually happening at a time of life when women are really busy, probably with teenage children, maybe with elderly parents, perhaps with high profile jobs. And it's all a bit of a juggle, and it can be really, really difficult. Now, as well as these symptoms, there's also some increased risks that happen during the menopause with the lower levels of estrogen, which include an increased risk of osteoporosis when the bones break more easily, increased risk of heart disease, and increased risk of stroke. So that is the slightly depressing part with the list of symptoms, but the next section is all about what we can do about it. So if we look at the next slide, so the diagnosis of menopause. So a lady who is over 45 who has typical symptoms, we don't need to do a blood test to confirm the menopause. We call that a clinical diagnosis. If you're the right age and you've got the right set of symptoms, then that is menopause. And if we just look at this graph, this again shows us why hormonal blood tests are not very helpful. So if we do a blood test to check hormones, if you look at how random all of those hormone levels are during the perimenopause, it's really hard to interpret blood tests. So we may get a definitive answer, but we may not, and we're then left saying, well, we maybe don't quite know what's going on. So if you're the right age and you've got the right symptoms, we don't need to do that blood test. Sometimes we do blood tests in women who are particularly young going through menopausal symptoms, and we also sometimes do blood tests for other reasons. So we may want to check things like thyroid function or check for anemia as well. So then moving on to what we can do about menopause, so different treatment options. So there's some lifestyle things that we can do. Basically, the healthier you are, the better you'll cope with the menopause. And it's also important to be healthy to maintain bone density and muscle mass. So things like regular exercise, healthy weight, don't smoke, don't drink too much, good diet, all of the classics. And we'll hear a little bit more later in the webinar from Sarah about some of these things. Good sleep hygiene is also really important. So maintaining good sleeping habits, particularly if the menopause is causing disturbed sleep. And anything that can be done to reduce stress levels and to promote relaxation is good too. Then some non-hormonal options. There are some herbal remedies available. The evidence isn't great, but some women like to try them. We sometimes also use antidepressants, particularly to help with hot flushes or some of the mood changes. Things like counselling or CBT, so cognitive behavioural therapy, can also help. And techniques such as mindfulness for relaxation can be good. But HRT, hormone replacement therapy, is of course the big one that I as a GP am dealing with a lot. So we're going to the next slide. In HRT, we want to give back the estrogen that your body is lacking through the menopause and perimenopause. And there have been lots of fears around risks of this in the past, and historically it hasn't been very well handled by doctors. But actually now the evidence shows that for the vast majority of women, the benefits of using HRT outweigh the risks, and it can be brilliant. So that whole list of symptoms, a lot of those things can be dealt with by giving you HRT, and it can be a really satisfying consultation for me as a GP, because women come back and they say, "You've changed my life, I feel myself again." It can take a little bit of tweaking to find the right dose or the right preparation, but we usually get there in the end. So the main component is estrogen, as we said, for the symptom relief. So remember, we said at the beginning how many bodily processes that is implicated in. We looked at that whole list of symptoms. That's why we need to give back the estrogen. And then progesterone is also really important. So if you still have a womb, so you've not had a hysterectomy, then the progesterone is needed, which protects the lining of the womb from thickening, which reduces the risk of womb cancer. So estrogen by itself can lead to thickening of the lining of the womb, and the progesterone helps to prevent that. So both things are really important. The estrogen deals more with the symptoms, although progesterone can also help sometimes with sleep and with period control. And there's different ways to give the estrogen and progesterone. There's different dosing regimes depending on how long ago your last period was and what sort of bleeding pattern we would expect. And it can be complicated. It's complicated even for doctors, to be honest. It can take a while for us to get our heads around it. So I think it's really helpful if you were to be speaking to your GP about menopause, if you have a bit of an idea of what to expect in terms of your treatment options. So we're going to have a whistle-stop tour of some of the different methods, and then we'll talk a little bit about the risks of HRT, what we do when starting and stopping HRT, and some of the problems that can arise from it. So if we go to the next slide. So the first choice is whether we have continuous or sequential HRT. So continuous is the same hormones every day. Sequential is the hormones change through the month. So you have 2 weeks of just estrogen and then 2 weeks of estrogen and progesterone. And that determines whether or not you get a monthly bleed with the HRT. The next choice is whether you need combined HRT, so both of the hormones, so estrogen and progesterone together. And if you want to take them both together, that can either be given as a patch or as a tablet. And then the third method is estrogen only. So estrogen only, if we just have the next click on the slide, estrogen only comes in these different forms. So it can be a tablet, it can be a patch, it can be a gel, which you rub into the skin, or a spray, which you spray onto the skin. And so estrogen only is suitable for a lady who doesn't need progesterone because she's had a hysterectomy, or you can have estrogen only, and then you can have the progesterone in addition. So if we have the final click on the slide, the progesterone component can be through the Mirena coil, which I'll talk more about in a second, or it can be as a progesterone tablet called Estrogen, which is a type of progesterone that is really closely aligned with your body's natural progesterone. Now, the most popular HRT at the moment, sorry, my circle is slightly wonky. The most popular way to give estrogen is through the skin. So my circle should be slightly lower, and it should circle patch, gel, or spray, because those are the ways that you get estrogen in through the skin. And that is most popular because that is the most close to your body's natural estrogen, and because it has just the best safety profile in terms of no increased risk of blood clots if you have estrogen through the skin. And then the progesterone, either as the Mirena or the Estrogen tablet. So just a moment about the Mirena coil. So lots of you have probably heard of this. It is really good for controlling periods. And as we mentioned earlier, one of the symptoms of menopause can be to have really heavy or irregular periods, which can be really miserable. So the Mirena is great for that. It also acts as a contraceptive. It's a small T-shaped device. It's kind of about 1 inch wide and long. It's inserted into the womb during a procedure, a bit like a smear test, slightly more uncomfortable. And then once it's in, the coil releases the hormone progesterone. The hormone stays locally just within the womb, and it thins down the lining of the womb, and that protects the womb, as we said, is needed, and also helps to reduce or stop periods. It's also called an intrauterine system. Now, with this big long list of choices, it can seem a little bit overwhelming. It's all about individual choice and a discussion with a doctor about what suits you best. Some women arrive in my consultations really keen on one particular method. Others want a little bit of guidance about what I would recommend to them. And sometimes something suits a woman more than something else, and it can be a little bit of trial and error to get to the right one. So if we go on to the next slide. So important to say that HRT is not contraception. So officially, a woman is fertile until the age of 55. That is, unless menopause has been absolutely confirmed, which means a year since the last natural period if over 50, 2 years if under 50, or if some blood tests have been done and procedures have been followed to confirm that menopause has happened. Without that, you need contraception until you're 55. So a lot of women end up with contraception as well as HRT, unless the Mirena coil is used as the progesterone component, which then does both. So the other types of contraception could be the mini pill, the progesterone pill, or condoms, or perhaps the partner has had a vasectomy. And it's fine if women end up on 2 forms of progesterone. And then the next thing on that list, the topical estrogen. So this is another aspect of HRT. So we said one of the gynecological symptoms of the menopause can be vaginal dryness, or the long name. So there's vulvovaginal atrophy or atrophic vaginitis. And that word atrophy or atrophic basically means dry and shriveled. And the vulva and the vagina without estrogen can get dry, shriveled, painful. It can make you more prone to urine infections. It can be really uncomfortable. It can make sex really painful. And actually with painful sex combined with the loss of libido that can come with the lack of estrogen in the menopause, it can create this vicious circle leading to a really unsatisfying sex life for both partners. But it is very treatable with topical estrogen. And again, the difference can be amazing. So 3 months of topical estrogen can just really help to plump up the tissues around the vulva and the vagina and make everything kind of plump and moist again like it should be. So topical estrogen is available as pessaries. Like one of the brand names is Vagifem. A pessary is like a little tablet that goes into the vagina. It can be a cream. One of the creams is Ovestin, and that can be used just with a finger to rub onto the area, or with an applicator to insert it right into the vagina. And there are some estrogen pessaries which are now available to buy over the counter. You don't even need a prescription, which is brilliant, and just an example of kind of a step forward in the menopause being much more widely recognized in society. And then the final thing on this list is testosterone. So this is still perhaps slightly controversial in HRT management. It is available in private clinics and from menopause specialists. It currently is not licensed for women on the NHS, which just means that it hasn't gone through all of the kind of rigorous testing and study data to get a full license, but it doesn't mean that it isn't safe. It just means that there's more precautions around prescribing it. So testosterone has been proven to help with the low libido of menopause. That's the thing that the evidence is there for. The guideline is that somebody would need to be on maximum dose of estrogen before adding in testosterone to help libido. And there are lots of other factors to consider with libido, because as we all know, libido has multiple factors involved. It's not just about hormones, but testosterone can help with low libido, and some women do find that really helpful. There's some limited evidence for helping with energy or other symptoms. So currently the guidance is it can be used for low libido, and it tends to be prescribed by a specialist, but then we can take over the prescribing in the NHS if the right guidance have been followed and someone's been established on a dose with proper monitoring by the menopause specialist. So that is HRT, the different options in a nutshell. If we move on to some of the risks of HRT, so the big one is breast cancer, and this is the one that historically people have been very concerned about, and probably has been the main reason why women have not been given HRT in the past. There was some dodgy trial data. There was also a lot of trials done on quite old-fashioned types of HRT, but with modern HRT and much newer data, it's now considered that the risk of breast cancer is low for most women. So this picture hopefully helps to explain a little bit that for all women there is a risk of breast cancer. So this particularly shows women aged 50 to 59. So a certain number of women would develop breast cancer anyway. Women who take combined HRT, there may be 4 additional cases. Women who drink 2 or more units of alcohol, there may be 5 additional cases. Women who are smokers, there may be 3 additional cases. Women who are obese, there may be 24 additional cases. So actually, when linked up, when kind of shown against some of the other risks that can come from lifestyle choices that we probably don't think quite so deeply about, it shows that actually HRT is a bit like another lifestyle choice. And I think lots of women wouldn't think twice about having a glass of wine with dinner, but may really, really strongly consider, should I be on HRT because I don't want to get breast cancer? So hopefully that just helps to explain a little bit about how risks need to be taken into account against other risks and other choices. There are a few contraindications, so reasons why somebody definitely shouldn't be on HRT. So having had breast cancer in the past, if there's some womb or bleeding issues that remain undiagnosed, if someone's got severe liver disease or untreated blood clots, very high blood pressure or recent heart attack. Those are all things which we would need to get specialist advice before starting somebody on HRT. But actually that list is quite small and doesn't apply to most women. So for the vast majority of people, HRT is likely to provide some benefit. So we're going to the next slide. So when we're starting and stopping HRT, so it would be an initial consultation with a GP and to go through options and make some choices about which HRT to start. And then we would usually do a 3-monthly review to see how things are going. It can take about 3 months to get used to HRT. So that would be for any side effects to settle down and to just see the full benefit from the dose that you're on. And at that review point, we may increase the dose if needed, or we may switch to something different if that seems more appropriate. In terms of stopping HRT, there isn't really an upper age limit or any hard and fast advice about this. It's more a question of every year just reviewing the risks and benefits and see if things have changed. Some women want to continue on HRT because they feel so amazing. Other people feel like they're probably through the worst of it and would rather kind of settle down into a new normal of being postmenopausal. And at that point, we would then kind of guide people through perhaps tapering down the estrogen doses and just remaining in control of what's happening there. But it is an individual choice, and I have got patients who are still on HRT in their 70s, and I wonder if that might continue as we are using HRT more and more. Now, there can be some problems with HRT. So that's the next slide. So the biggest one is bleeding. So I see a lot of women who get bleeding on HRT. If that's in the first few months, that's fine. That's kind of to be expected, just as the body is getting used to the hormones. And sometimes with a bit of tweaking of what we're prescribing, the bleeding will settle down. Sometimes bleeding does need an investigation with an ultrasound scan or possibly a hysteroscopy, which is what the gynecologist in the hospital would do. Sometimes bleeding problems on HRT can be solved by having a Mirena coil inserted. There can be side effects with HRT, particularly from the progesterone. So these could include sore breasts or bad skin, a little bit like some of the side effects people get with PMT. Usually these settle down again as the body gets used to it. But if needed, we can change or increase the progesterone or the Eutrogestan capsules that we talked about. They can be used vaginally rather than taken orally, and that can help to settle down the side effects as well. And then sometimes HRT seems to be ineffective or doesn't seem to be working, or sometimes it maybe is working a little bit, but women say, like, I feel a bit better, but it could, you know, I could have more, in which case we can increase doses. And again, there's kind of guidelines and maximum doses with what we do with that. Sometimes we also do a blood test to check whether the estrogen is actually being absorbed properly into the body through the delivery method. So that is menopause and HRT in a nutshell. As I said, bit of a whistle-stop tour just to try and just get some of the information across. I think one of the key things is it's not one size fits all. It can be more nuanced, and some people do need specialist input if there are unusual cases or if there's problems with it. But GPs are very good at the basics of menopause care. And as I said, it hasn't always been very well handled in the past, but now most doctors are very pro HRT. And often for somebody of the right age with the typical symptoms, the mindset is, well, let's give it a try. Let's have a 3-month trial of HRT and see whether things improve. So if you are getting some of those symptoms or you just want to talk more about it, please don't be shy about going to see your GP. And if we just look at the next slide, there's some resources on there. So these are a list of websites that I find really helpful. Those are things that when the information is sent around afterwards, you could have a look at. So thanks. I think that is me done. And then I'll happily take some questions at the end.
Wonderful. Thanks, Catherine. Exceptionally insightful. And yeah, we've got a couple of questions in there already, but we'll save them for the end and we'll move on to Sarah. Sarah.
Great. Hi, can everyone hear me okay?
Yeah, all good, Sarah.
Okay, fab. Okay, so hi everybody. I am Sarah Tyler. I am a women's health physiotherapist, and I've been a physio for 13 years, and I've been working in women's health for 10 of those years. It's one of my favorite things to talk about. I treat a wide range of conditions, so including incontinence, prolapses, pelvic floor dysfunction, pregnancy, postnatal conditions. But one of my favorite things that I love doing is supporting women through the perimenopause and their menopause years. So today we're going to be talking about how exercise can really help you through your perimenopause and postmenopausal years. We're going to be talking about why is exercise so important, what sort of exercise we should be doing, what barriers we encounter when we're trying to exercise, and why is pelvic health so important, and then where to get help. So these are my details at the bottom here. I'm going to go through some other details of where to get help a little bit later. Next slide, please. Fantastic. Okay, so as Dr. Cole has just said, we've had a brilliant talk from her. Thank you, Catherine. That was so insightful. She was just really highlighting the importance of estrogen. Estrogen is the water that helps the garden grow. Exercise cannot replenish your hormone levels. Only HRT can do that. But exercise is a really great way to overcome some of the symptoms associated with the perimenopause. So, as you can see on the screen, here are a broad range of reasons why exercise is the absolute non-negotiable during the perimenopause. So let's start off with bone health. As Dr. Cole just said, as we get older, our bone density decreases. And this actually starts during the perimenopause. It is estimated that it's about 3 million people in the UK are living with osteoporosis, so thinning of the bones. And that is 1 in 2 women over the age of 50, compared with 1 in 5 men. So it's affecting women a lot more, and this is mainly to do with estrogen. We do know that weight-bearing exercises are the most effective type of exercise for maintaining healthy and strong bones. We're going to go through that a bit more later. So on to cardiovascular health. As Dr. Cole also said, your cardiovascular health really does alter as we get older, mainly because there are estrogen receptors throughout our body. and estrogen plays a huge part in maintaining good cardiovascular health. So as your estrogen decreases, your cholesterol increases, and your risk of having a heart attack is 5 times higher when you are post-menopausal. Now, obviously, exercise is fantastic for cardiovascular health, so that's one of the reasons why we want to keep exercising and keep healthy. Okay, on to mental health. So as your brain is adjusting to all these erratic changes in hormones, this can have a really big negative effect on our mood, our thoughts, our feelings. And obviously we know that there's been a lot of research to say that exercise has been proven to reduce anxiety, reduce stress, improve mood, improve and boost confidence. But other things that could be affecting your mental health, such as not getting a good night's sleep, that can really affect your mood. I know it certainly does mine, but exercise can also improve insomnia, especially if you are moving your body first thing in the morning. This can reset your natural circadian cycle and reduce the likelihood of insomnia. So on to gut health. So estrogen, the wonder hormone, the estrogen keeps our gut tissues healthy and hydrated. So when there is a lack of estrogen, this really slows down our digestive process. But by increasing our movements, by increasing our exercise, this can improve digestion and reduce the risk of constipation. Now, constipation is something that is so common in the perimenopause, and often I see women in my clinic who have never been constipated in their life, but then as they go through the menopause, they're starting to get slightly drier stools. And again, just improving your movement, changing the different types of exercise you're doing can really help with this. On to hot flushes. So research has found that hot flushes were reduced by 40% if you are doing resistance training, so kind of weights, loading your muscle 3 times a week. Interestingly, they were not lower. The hot flushes weren't lower if you were doing lower intensity exercise like walking or yoga. However, we know that the yoga and things that are helping you to relax are really, really beneficial for this time. It's a very stressful period in our life. So yeah, yoga, as we're going to find out from Rianne later, is a great way to keep healthy. Finally, muscle mass. So as we age, naturally our muscle mass declines. It is estimated that it declines by about 3 to 8% each decade after the age of 30. That's quite young. And then that accelerates again after the age of 60. So it is so important to make sure we're keeping our muscles strong. Now, I haven't put down here about pelvic health. That is one of the most important things that we need to keep healthy and strong during the perimenopause. We're going to talk a lot about that in a bit. So next slide, please, Danny. Thank you. So what do we need to do? The World Health Organization recommends we do a minimum of 150 to 300 minutes of moderate intensity exercise a week. So about 5 hours a week. Moderate intensity, I kind of consider walking, walking, dancing, playing tennis, something like that. Or you could do 75 to 150 minutes of vigorous exercise a week. So maybe something like a game of netball, something a bit more vigorous. Plus, also it is recommended that we should be doing at least 2 sessions of resistance training a week. Adults over the age of 65 also need to incorporate balance work alongside their strength work, and this is where yoga is really fantastic. The other recommendation is to really minimize any sedentary sitting for long periods of time. Now, obviously with COVID, we all kind of moved over to Zoom. We're doing a long lunchtime webinar here where we're spending a lot of time sitting. And that is why it's fantastic that we've got Rianne to get us moving in a moment. Next slide, please, Danny. Hello? Oh. Okay, so 2 of the most important parts of exercise, types of exercise, are resistance training and weight-bearing exercises. However, I always maintain the best form of exercise for you individually is what you like doing best. You've got to move for joy. If you are thinking, right, okay, I need to go and lift some weights in the gym, but that's not your thing, and you really don't like it and you really aren't enjoying it, then that isn't the thing for you. You've got to find something that you like. So resistance training, as I've said, is really, really important for building those muscles and improving our bone density. It can feel very daunting for women who have never lifted weights before, but it's a really good idea to start off slowly. You can start off by doing body weight exercise. So, you know, just some squats at home, just some lunges at home, something that's really low level, starting off slowly and building it up. You can then move to resistance band or handheld dumbbell weights. Then if you have a gym membership, you could go around and start using some machine weights. And before you know it, you'll be deadlifting in the gym. So I don't know whether anybody on social media follows a lady called This Woman Lifts. It's a great place to start. She has a training program for every ability. And her mantra is, don't train to look good now, train for your old lady body, which I think is a great idea. You know, we want to keep ourselves fit and healthy for now, absolutely, but for the rest of our lives. Your bones and your muscles will really thank you for it. So going on to weight-bearing exercise, this is when repetitive strain on the bones helps increase bone density. So this could be walking, jogging, dancing, skipping. It can be high impact or low impact. But the Royal Osteoporosis Society has a program called Dance for Your Bones, which is a wonderful program. And it's a great place to start. But we do know that weight-bearing exercises is the way to build up that bone density. Next slide. Thanks. Okay, so it's really important to just acknowledge that there are many barriers to people exercising as they go through the perimenopause and the menopause. Once we've acknowledged these, we can then get an action plan to help you overcome them. So, for example, as Dr. Cole mentioned earlier, we're going to have, you know, this is a very busy period of our lives. You know, you might have time constraints, you might have money constraints, you maybe don't know where to start. You know, not everybody is a cross-fitting superstar, and that's absolutely fine. One of the main symptoms of the perimenopause is obviously weight gain, and that can really decrease people's confidence, and they don't want to just go out into a gym. You may also be experiencing some other musculoskeletal conditions. You may have fatigue as one of your symptoms. And so that is maybe potentially stopping you from training in the way that you want to. You may be looking after children. You may be looking after elderly parents. You may not have that time to prioritize your health. But one of the biggest reasons why people stop doing exercise or don't start doing exercise is pelvic health. So 1 in 2 women have said that they stop a particular form of exercise because of their pelvic floor dysfunction. And that's really, really important. And that is just a really good thing to remember. And it shouldn't be the thing that stops us, because with pelvic health, there can be lots of things that can be done for that. So some of my top tips: you want to start off slowly and build up in bite-sized chunks. You know, maybe start by just increasing your steps each day. You might want to try habit stacking. So for example, when you're cleaning your teeth every morning, which we just do absolutely automatically, you may want to start doing some marching on the spot. You may want to start doing some squats. I have a friend who every time she cleans her teeth, she does 50 squats. And I love that. It's a great way to do it, because every time you clean your teeth, you're just getting in that extra bit of exercise. You could do it with a friend, make it sociable and also beneficial to your health. Sometimes people find using an exercise diary is quite a nice way to keep yourself accountable. There's a really lovely app that I use called Don't Break the Chain. And if anyone's slightly OCD like I am, it is really, really good because you tick off every time you've done some exercise and you're not meant to break the chain. And it's a good way of keeping your exercise on track. The other thing that could be quite useful is to give yourself permission to prioritize your health. So often we are so busy looking after our children, looking after our partners, looking after our parents, that we don't actually give ourselves permission to set that time aside in each week and say, yeah, no, this is just for me. It's quite important to maybe set some goals. So what do you want to achieve? Either with a specific exercise plan or an objective goal. So for example, I want to be able to lift such and such by Christmas. My main tip though is never underestimate the importance of pelvic health. So next slide. Okay, so pelvic health, this is my absolutely favorite topic ever, and it's such an important part, and it affects so many people and can, as I said, 1 in 2 women stop their form of exercise because of certain pelvic floor dysfunctions. So just very, very briefly, pelvic floor dysfunction includes stress incontinence. That is when you have too much pressure pushing down on the pelvic floor, and that causes you to leak urine. So quite commonly, things that I see in my clinic are things like coughing, sneezing, but also people who are already fit and healthy, they're going to exercise classes, but they can't do high knees, they can't do star jumps. Lots of women stop running because they end up leaking urine. And this actually is 1 in 3 women are affected by having stress incontinence. Pelvic organ prolapse, and I'm going to talk about that in a moment, but this affects 1 in 2 women. Urinary urgency, so people are sometimes stopping exercise because they're worried that they'll constantly need to go to the toilet. Fecal incontinence, so leaking some stools. Flatus incontinence, so lots of people say I don't like going to yoga anymore because I just end up farting the whole way through. Or pelvic pain, so people are actually stopping exercise because they're getting some chronic pelvic pain. So next slide, please. So pelvic organ prolapse, I don't know how many of you have heard of this before. This is when either the uterus, the bladder, or the bowel descend into the vaginal canal. Quite typically, this presents as a heavy, a dragging feeling in the vagina, almost like you haven't changed a tampon. Sometimes it can cause backache. Sometimes it can cause incontinence symptoms or leaking stools, or sometimes it can feel that you can't fully empty your bladder or you can't fully empty your bowels. Now, if you are suffering, as 1 in 2 women do, with a pelvic organ prolapse, it is absolutely vital to be strengthening our pelvic floor, so that underneath support, because this is one of the biggest barriers to people not being able to exercise for their old lady body because they try to exercise, they try to do weight-bearing exercises, but their pelvic organ prolapse is stopping them from doing it. It makes them feel like it's going to get much worse. And that is why it's really important to look after our pelvic health. Next slide, please, Danny. Okay, so how do we look after our pelvic health? So absolutely, research still shows that we need to be doing isolated pelvic floor exercises. This is an absolute must for all women, whether they are 20 years old or 70 years old, but especially through this perimenopausal time where we know lack of estrogen creates this vulvovaginal atrophy. So the muscles are less plump, and that can mean there's less support for the pelvic organs above. We want to make sure that our pelvic floor is strong, has good endurance, but also has good flexibility. So we don't want a pelvic floor that just kind of sits up and down like this. We want it that can come all the way up and all the way down. We need to make sure that our glute and our leg muscles are strong. So lifting weights is a really good way to support our pelvic health. So keeping our glutes, our quads, our hamstrings, our adductors, all of those muscles in your upper thighs really nice and strong. We want to make sure that we are managing any constipation. Constipation is one of the worst things you could have for your pelvic health. So making sure we're drinking enough fluid, making sure we're eating the right nutrition, making sure we have the right toileting habits, which sounds quite bizarre to say, but actually it's really important to make sure that we are opening our bowels in the right way. Sometimes people find using a footstool is quite a useful tool, but also we want to make sure we're using our breath. So our diaphragm, the big muscle, I don't know whether you can see, oh, hold on. So the big muscle that sits underneath our ribs here, our diaphragm and our pelvic floor are the top and the bottom of our core cylinder. So if one isn't quite working, the pelvic floor, then likelihood is the other's not working, because they actually are meant to work together like that. So that's why another reason yoga is such a fantastic tool for perimenopausal women, getting sure that we're connecting with our breathing patterns. One of my services is I provide a menopause MOT, and this is just going through everything to do with your individual perimenopause, and then building you an individual exercise program. Now, it's not just me. There are many women's health physios all over the country, all over Essex. And if you go to the next slide, please, Danny. So if you are looking to find help for any of the symptoms that I've discussed today, the POGP is a really, really great directory. The Squeezy app is a great resource, and this is a great app that is designed to help people start working on those isolated pelvic floor muscles. It's a great start. Download it today. Download it now. And if you are looking for a local women's health physio, they have a great directory on that app as well. The other place is the Mummy MOT directory. So if you are looking for any help and you feel that you should get your pelvic health assessed, which everybody should, then go through some of these directories. For now, what we're going to do is go through how to do your pelvic floor exercises very quickly. Oh, hold on. Okay, so I don't know whether you can see me. Can you see this here? Yeah. Okay, so everything that you see that's red here are your pelvic floor muscles. So if you put your hands together like this, that is how wide and big your individual pelvic floor muscles are. So they're quite big, aren't they? They're a lot bigger than a lot of people think. And lots of people say to me, so this is the vagina, lots of people say, oh, I thought they were just two strips down either side of the entrance to the vagina. No, they're much, much bigger. If we look at the anatomy, this is your back passage. So this is your anal sphincter. And if we look internally, can you see this hole here? Again, that is your anal sphincter. So look how much of the muscle fibers are actually around the back passage and not the vagina. So when we are doing pelvic floor exercises, we need to make sure that we are imagining my model here and thinking what we are trying to work. We're trying to work out this pelvic floor, but starting around your back passage. So you want to be thinking to yourself, okay, we want to squeeze around your back passage, squeeze around the front. Then you want to pull it all the way up and then fully relax. But if anyone's done Pilates, we know that we do all this movement on the exhale. So I would encourage you to inhale. Everyone try it now, okay? Everyone put down your lunch, try it now. So we're going to inhale through your nose. And as you exhale through your mouth, You imagine you're squeezing around your back passage as if you're trying to stop yourself from farting. Squeeze around the front as if you're trying to stop yourself from going for a wee. Pull up and then fully relax down. Let's try that again. Inhale through your nose. Exhale through your mouth. Imagine you're stopping yourself from farting, stopping yourself from weeing. Pull all the way up and fully relax down. Ideally, we would do that 10 times in a row, every single day. And if you're having any symptoms, at least 3 times a day. Then what we also would like to do is work on the endurance. So we need to do that exact same motion, but hold it for as long as you're able to. So for example, let's start off with 5 seconds. Let's see if we can all do that now, okay? So ready, inhale through your nose, exhale through your mouth. Imagine you're stopping yourself from farting, stopping yourself from weeing. Pull up and hold. 1, 2, 3, 4, 5, and relax down. Now, ideally, you wouldn't be holding your breath and you wouldn't be holding your shoulders up and your glutes wouldn't be going up and down. You would be able to just be nice and calm. You may be able to speak as you are squeezing and holding. Then over time, you can build that 5 seconds hold up to 6 seconds, up to 7 seconds, all the way up to 10 times. Research shows that if we're trying to improve the strength of our pelvic floor, we need to do isolated strengthening exercises, 10 of the quicker ones, which aren't actually that quick, and then 10 holding for about 10 seconds. That is what we're aiming for, but that is not suitable for everybody. So I would say get assessed. It's a good idea to build up your own individual pelvic floor strength at your own individual pace. I hope that will make sense. It's very difficult to do on a webinar. But Danny, I think that is me done.
Sarah, that was absolutely fantastic. Thank you. The
No
top
worries.
tips and practical elements that you've given those on the call today is been brilliant. And even I was sat here in the office in Chelmsford County Hall
Good.
practicing a few
Funny
odd
words.
looks as I was inhaling and exhaling, but fantastic.
Good.
Thank you ever so much, Sarah. Thank
No
you.
worries.
Wonderful. And that leaves me to introduce Rianne. So as Sarah's alluded to in her presentation, obviously yoga has some fantastic benefits for those at perimenopause and menopause, as well as obviously other exercises. But Rianne's going to join us now to take us through a short yoga session. So Rianne, let's first and foremost check that you're here, which I believe you are. Wonderful. Hopefully you're able to unmute yourself.
Can you hear me?
Yes, we can hear you.
Hello. I think my video's switched off. Hang on, let's see if I can.
Yeah, no worries. I might have the key to that. So hopefully you've now got an opportunity to share your video.
Let's have a look.
Amazing.
Wonderful. Hello, everybody. Thank you, Sarah and Catherine. That was wonderful. I really enjoyed seeing the actual pelvis as well. I think that's such a good representation of where the muscles are. So yeah, thank you. So I'm Rianne and I am a yoga teacher and a yoga therapist based in Epping. And I have been teaching yoga for almost 12 years now. And the work that I do as a yoga therapist is in supporting lots of different individuals with their health challenges, and that includes sometimes just working with them on a little bit of symptom management or just generally helping to improve their overall well-being. So how can yoga support an individual through the perimenopause and menopausal years? Well, yoga is a holistic practice, so yes, it's body-based, and I'll do a little demonstration with you in just a few moments. But yoga is really good at helping to support our emotional and our mental states as well. So it's a lovely, holistic, full-rounded practice where we're looking at the person as a whole rather than just the individual bits that make up that person. Yoga is very accessible now, particularly after COVID. You can actually get lots of fantastic videos online. and I can send over some links to those if anyone wants them afterwards, of just some really good sequences that you can practice at home. It's a brilliant adjustable practice. So if the individual might be working with an additional health challenge, the yoga practice can be adjusted to meet those needs as well. So I'm going to demonstrate for you a short practice. Hopefully some of you managed to join, and just to give you a little bit of a context as to what this is aimed at, it's a home practice. So in the yogic tradition, you normally work with your yoga teacher, and that could be in a group to begin with, but then you start to have your own home practice. So having a home practice is a wonderful tool, and I think it really breaks down, when you was talking, Sarah, about some of the barriers to exercising, being able to do this at home on your own, have the confidence to just do a 20-minute sequence, maybe first thing in the morning or whenever you can squeeze it in around family and work. It can feel really empowering. You don't need to go to a gym, you don't need any weights to do it, you don't necessarily always need a yoga mat either. So to be able to just have a little bit of time for yourself every day to work through your physical practice is a really good way at just tuning into your body, figuring out how you feel that day, and then just noticing as you maybe feel a little bit stronger, maybe you're able to balance a little bit easier, maybe your body starts to feel a little bit more mobile as you work through. So I'm going to demonstrate now a 10-minute sequence. I normally recommend 20 minutes, but what you would normally add on then is a little bit more relaxation. So I won't do that with you today because you'll all probably fall asleep and you've probably got to get back to work. So the components of the home practice that I always offer is, firstly, some kind of flowing movement sequence. So together in a moment we're going to do the sun salute sequence together. So the flowing sequence will really start to lift the heart rate. It has that cardiovascular element to it. We'll then move into some really great classic yoga balances together, and we'll look at how we might build on those as we progress and get stronger. There's strength-based work that we would include in that short practice. And then always, we're here talking about exercise, but I'm actually a massive advocate for rest, and active rest, purposeful rest, where you're not just sitting in front of the telly, but you're actually being still and mindfully being still as well. So we'll do a little bit of that together. So if you're able to, bring yourself to a position where you are standing up. I'm going to demonstrate now the sun salutation sequence. So this is a fantastic practice for increasing your mobility, but also your strength. It's a really good warm-up based practice as well. And so we start this with the feet together. I'm going to turn to the side so you can see what my body's doing. And then just drop your arms down at the sides of the body, let your shoulders relax, just take a moment to tune into any tension in your jaw or around the abdominal region. And then we start with a breath in, and the arms elevate up into the air. So you can close the palms together if that feels comfortable. As we breathe out, we're bending the knees and coming over into a relaxed forward fold. As you take your next breath in, place your hands on your shins, lift your chest halfway back up. Feel the muscles in your back beginning to activate. And then we come down to weight bear on our hands. The palms make their way down to the mat. With the shoulders on top of the wrists, take the legs back behind you. You can bring your knees straight down to the floor, or if you can, slowly start to bring yourself down in one long line. As you take your next breath in, gently press into your palms. Use your spinal muscles to lift your chest. From here, gently release the chest back down. Tuck the toes, press into your palms, and then we're lifting the hips up and back behind us. So we're coming into a downward facing dog. And this is always a good place just to notice how your body feels. Just becoming aware of any of those little pockets of tension that you might be carrying in your body. Keep pressing down through your palms, and then when you're ready, as you take your next out breath, gently bend through your knees and start to walk your feet towards your hands. So your hands might need to come back halfway to meet your feet. When you arrive there, take a gentle forward fold, so fully relaxing. Inhale, sweep the arms up into the air, close the palms together. And exhale, drop the shoulders, relax the jaw, soften the arms down. So we'll do that twice more. So you should feel by the third round, just that little elevation through your heart. Inhale, lift the arms up, gazing up towards your palms. With soft knees, we come over into a forward fold. Inhale, lift the chest halfway back up. Bring your hands to settle at your shins. And exhale, we're back down into weight bearing through our wrists and palms, stepping the legs back to plank pose. Gently engage through your core. Bring your knees to the ground and then slowly lower your hips and your belly down to the floor. Inhale, lift up through the chest. And then exhale, tuck the toes, come up into downward facing dog. So as you pause here, just focus on the sound of your breath. And as the sun salute sequence becomes a little bit more familiar, you can end up creating what feels like a bit of a meditation in this practice, so that you're accessing the mind and the body together. Take a little bend through your knees, look forwards, and then again we're walking our feet to the top of the mat. When we arrive, we're in our forward fold, we're letting the head drop down. Inhale, lift the arms up. Feel the weight of the head stacking on top of the spinal column. And then exhale, release. We've got one more to do together. Inhale as you take your arms up into the air, gaze up. Exhale over into your forward fold. Release the weight over the thighs. Inhale, lift the chest halfway back up. And exhale into your plank pose. So taking your legs back. Brace your core a little there. Bring the knees down or float down in one long line. Lifting up through the chest, breathing in. And breathing out as you press back into your downward facing dog. Hips lifting up and back. So in your down dog, feel your tailbone lengthening away. And maybe take a moment here to notice the body warming from the inside. The breath might have changed in pace and depth. You might be able to feel your heart rate has lifted a little. Take a bend of your knees, look forwards, and then walk your feet back towards your hands. Relax over the thighs, exhale. Lift the arms, inhale. Relax the arms down, exhale. And I'm just going to get you to pause, have your feet hip distance, and then bring your hands onto your chest. So you might be able to feel the presence of your heart. Then on the out breath, let your arms drop down. So that's the sun salutation sequence. Again, it's a really good one at increasing your mobility and also the strength. It's quite, if you were joining in, you might be able to feel it's quite a challenging little sequence. So five of those rounds could take about 10 minutes, and it's a really good one to build a little bit more of that cardiovascular health. So we'll come into a balance pose. The first thing that you want to think about when you're in your balance is where your pelvis is. If I stand this way, the feet are underneath the hips, and in the yoga tradition we bring the hands together, but you could do whatever you want to. You could bring the hands to your hips. If you struggle with a little bit of your balance, feel free to hold on to something as well. So bring the weight of the body over to the right foot and then slide the left toes in. So it could be, to begin with, that your toes are just on the floor. It might be that you lengthen the heel up so it's settling at the calf muscles or above the knee somewhere. And then this is the important piece. So we could be in our tree pose and not really be activating our muscles very well. We could sort of be sinking out into our hips. But think about your rib cage hovering on top of your pelvis and squeeze inwards through the inner thighs. So take a moment there. And we'll come to the other side just to see how that side feels for us. It could be that you're a little bit more wobbly on one side. So we've got that weight bearing element down through this supporting leg. And then release that leg down. So if that felt super easy to you, you could add on with your balance if you wanted to, and you could add a little jump into it. So the second time round, if you wanted to stay with your tree pose, you could come back to this shape. If you want to add on and build a little bit more challenge into your posture, You're going to take one foot back behind you and leave the other foot forwards into a lunge. So I've got my right leg in front of me, the left leg is back. I'm going to reach the arms up into the air and we're going to add a little hop. So this is warrior one. On the out breath, we're going to swing our arms back behind us and hop onto this front leg. So I'll show you what I mean. Little hop and then back into a balance. So that leg comes forwards, inhale, exhale. So you could probably feel, you don't need to do too many of those before you feel the effects of that movement on your body. And if you're in that position, change sides now. This is helping to support your balance, your coordination. It's giving you that little bit of extra challenge. So we'll just do one more of those. Little hop. And then you can release. So we're going to come down onto the floor now. Hopefully you have enough space around you. And I'm just going to demonstrate a bridge pose. So coming down onto your back, have the feet hip distance, and then lengthen the arms down at the sides of the body. So just take a couple of breaths there. You want to feel the knees pointing up towards the sky, a little bit of engagement through the inner thighs. Take a breath in. As you exhale, press down through your heels, lift the hips up slowly. So get a sense of pressing down evenly through both feet. The knees are being sent forwards over the middle toes. You're working through your glutes. The hamstring muscles in the back body are working. You're opening the hip flexors. These muscles can get a little bit tight if you're spending long hours of a day sitting at a desk. Take another breath there. And then slowly exhale to release. So bringing your spine back to the floor. Bring your knees into your chest and then just release your tailbone. So bring yourself back up. I'm going to come back to the screen. So with your bridge pose, that type of movement helps with the strength that you want to increase in the muscles. And you can add on, so you can do your bridge halfway back down and then lifting back up. You could stay there a little bit longer, for example. So the last component of a home practice is really important to end with some kind of relaxation. And yoga's been shown to really help to support women with sleep, or anybody with sleep. But doing this type of practice just before bed, blending together breath work and relaxation practices is really good at helping all of the sleep hormones, so the cortisol starting to reduce and the melatonin starting to increase, to help us to sort of set ourselves up for sleep. So let's come together. We're going to do a breathing practice specifically supporting a cooling down of the body. So it's called sittily breathing, and I'll demonstrate it. You might feel a bit ridiculous to begin with, but it's a really lovely practice for women that are experiencing hot flushes. So the first thing that you want to do is try and make a little straw-like shape with your tongue. So you're going to poke your tongue out and see if you can get the edges coming together. And if you can't, then you can just imagine that you've got a straw in your mouth. So you could do this movement instead. Then you're going to breathe in through your mouth. Close the mouth. Breathe out through the nose. Breathe in through the mouth. Close the mouth. Breathe out through the nose. So we'll carry on just for a few more rounds. And then just notice with the next couple of rounds, if you can feel your exhale becoming a little bit longer naturally. And usually when the exhale is a little bit longer, it's a sign that we're moving into our parasympathetic zone. So we're really in that relaxation space. So we'll take one more breath. And so the last thing that I always try to encourage people to do is just take a few minutes for themselves in active rest. So you could just be laying down on your bed. You could use your yoga mat, you could use yoga bolsters or props to support your body. And you just want to have just a couple of minutes for that final little relaxation. So I think that's everything from me. Thank you, Danielle.
Wonderful. Thanks, Rhiannon. That was absolutely fantastic. Again, sadly, I couldn't take part because I'm in the office, but the breathing element was very, very good. That's something I was doing. And it's interesting you made the point about longer exhales. So yeah, definitely noticed that. So thank you very much. And a fantastic way to combine everything that's been discussed today, the medical lens, the practical lens, and actually individuals being able to see that and experience that firsthand. So thank you very much, Rhiannon, for tying the knot beautifully. That was brilliant. Thank you. So before we close, we did offer the opportunity for those attendees to ask any questions, and I can see that there are 5 currently in the chat function. So what I will do is read them aloud, and hopefully between the panel, so Rhiannon, Sarah and Dr. Catherine Cole, hopefully one of you will be able to answer them. And if not, and we need to go back to that particular individual, we can do as well. I think that's absolutely important that we say that here. It also is another opportunity, should anyone want to ask any additional questions while these ones are being answered, please do pop them in the Q&A section or in the chat function. So the first question is, can HRT be done if you are on other medication, for example, medication for diabetes or arthritis medication? Dr. Catherine Cole, I do feel like that one is definitely more directed to you.
Yeah,
so
that sounds like that's probably mine. So the answer is yes, and this is where it being kind of an individual discussion would come in. So whatever medication you're taking, that would need to be looked at with your GP. But there, for most people, whatever medication they're on, HRT is fine.
Wonderful, thank you. Brilliant. Second question. I've heard lots of stories about women not being able to get the Mirena coils removed for over 6 months when they're not working for them. What has caused an issue with removal, and should women be cautious of using the coil for this reason? Dr. Catherine Cole, I do think that's another one for you.
I'm sorry that you've had that experience or heard those stories. I think like COVID did cause some backlog, and it might depend on the training of the health professionals like linked to your surgery or in your area. Certainly for us in our surgery, the nurses will remove a coil, and it's a really quick procedure. It's a speculum examination. It's get hold of the coil threads, 1, 2, 3, cough, pull, and out it comes. So it should be something really quick and easy. So I think if you're struggling to get a coil removed, just keep pushing and keep trying to get that appointment. And they should do it in the sexual health clinics as well. So yeah, hard to answer completely why it's happened, but just to reassure you, it is something that is quick and easy to do. And we have had women where I've put in a coil, and within a few weeks they're really not getting on with it, and we will remove it for them. We tried to encourage people to persevere for a little bit, because sometimes side effects take a while to settle down, but it's your body, it's your choice, and so we would always do what we can to take it out as soon as possible.
Wonderful, thank you, Dr. Cole. Next one is around will the slide deck be shared, and I can absolutely answer that. Yes, the slide deck will be shared, as will the recording, albeit that there's going to be a little bit of editing, so obviously had a unexpected two-part webinar, but it will all be available and look nice and clean when it is shared with you guys. Another question, how long does the perimenopause last? Dr. Catherine Cole.
Okay, so a bit variable. The kind of figure that I've got is the average is somewhere between 2 and 7 years, but in some women it is much longer, and there can be symptoms that perhaps looking back you might think, oh, actually I have been noticing this for a long time, but I think it is worth saying that some of the symptoms that you can attribute to perimenopause might be due to something else. So if you're kind of in your late 30s, early 40s, and you're not sure why while you're feeling tired, for example, is it perimenopause? It is worth going to see the GP and perhaps getting just a set of blood tests to check for things like anemia or thyroid problems or just other causes of why you might be getting some of those symptoms. But perimenopause can be long, which is one of the reasons I think it's so important to know about it and to learn what we can do to help you through it.
Absolutely. And I think it echoes all of your points, actually. Everyone is individual, whether that be finding the right exercise for them, whether it be going through the journey of perimenopause and menopause. Everyone is very, very different. But the more we talk about it, the more we share experiences, the more we have really open and honest conversations, that will hopefully help individuals. So next question about dosage. My doctor said that I'm on the maximum amount of HRT and a private prescription would be needed to get more. Are there any risks associated with taking more?
So to some extent, the jury's out a little bit on this one. There are licensed doses that are kind of recommended, and then there are doses that go beyond that are less recommended for sort of like general doctors to prescribe, I suppose. But in the specialist menopause clinics, they do sometimes go to higher doses. Often, if the dose of estrogen increases, the dose of progesterone has to be increased as well. So it's just important, I guess, to ask that question. If estrogen doses are going higher, just make sure, do I need some extra estrogen? Sorry, do I need some extra progesterone to counteract the effects of the extra estrogen? But that can be possible in the private clinic, certainly. And I guess any specific questions about safety you'd need to check with the doctors, but there are ways to mitigate what could be seen as extra risks.
Wonderful, thank you. And again, just to reiterate Dr. Cole's comment there, obviously if there's anything individualised to you, please do go back and check in with your GP. They'll obviously be alongside your journey and be able to kind of guide you as and when needed. Any advice for women who have had hormone positive breast cancer to help ease their symptoms?
Yeah, no, they don't look
So
familiar,
this is a bit of a tricky one. So if you've had hormone positive breast cancer, HRT is generally not advised. There are some of the antidepressant medications that can sometimes help. Sometimes it's worth trying with some of the herbal stuff, but there has to be care taken to make sure that those herbal remedies are not things that are going to activate estrogen receptors and possibly cause a recurrence of cancer. So it's a really tricky area, basically. I would be nervous prescribing anything hormonal to someone who's had breast cancer. And often I would be getting specialist advice about how to deal with you in that individual situation, and just to try to give the best outcome, because it's often, having had breast cancer, often the treatment can push people perhaps into an earlier menopause than they would have had otherwise. So that is a really important area of practice that we need to get right for women. So again, it's individual, but I would be getting specialist advice to help through that, and potentially the antidepressants would be important. And then I think that's where all the lifestyle stuff, so things like exercise, whatever exercise you want to take, and all the other healthy lifestyle stuff, that's really important too. And sometimes the psychological therapists, say things like cognitive behavioral therapy or counselling or mindfulness, all of those kind of things can have a really, really big part to play there too.
Wonderful, thank you. Dr. Catherine Cole, I'm going to pass this next question on to Sarah, so you can have a well-earned break. Sarah, can you get women health physiotherapists on the NHS?
Yeah, this is a really good question, and I'm so sorry that I didn't mention this before. I'm in the private world, so I keep thinking about private world now. So yeah, absolutely. So I used to work for the NHS as a women's health physio. That's when I first started my career in women's health. I was at Queen's Hospital in Romford. They've got a fantastic team down there, and I was with them for 5 years. And now in London, you can get lots of women's health physios. You know, they are all over London. Unfortunately, there's not as many of us in the NHS around Essex. There are, so EPUT, which is the Essex Partnership University Trust, which covers St Margaret's Hospital, Herts and Essex Hospital, and other little locations around this part of Hertfordshire and Essex. Yes, there is a bladder and a bowel team. So it's not technically women's health physiotherapy, but it's a bladder and a bowel team, and there are physios who work there. And so, yeah, absolutely. If you want to be referred via the NHS, I would highly advise that you go through your GP and not ask for women's health physio, but ask for the bladder and bowel team. So that's just around this area. Also, Addenbrooke's have got a fantastic women's health team there. I think there's about 4 women's health physios who work up at Addenbrooke's, and they are a fantastic team as well. You can get so many good resources online, and if you are wanting to look for some kind of just things that you can look at online, the POGP, as I said before, that is the Pelvic Obstetric and Gynae Physiotherapy Society. They have lots of patient information books, so that you can just download for free. So there's lots and lots of free resources on that website. Equally, the Squeezy app, that is an NHS app, and there's loads of information on that app as well. So yeah, those are 2 kind of ways that you can go get some kind of resources. But yeah, the short answer is yes, you can.
Wonderful. Thank you for that. That's very helpful. I've got a couple of questions just to end. I don't think there's anything else that's come into the chat. So one of the questions I jotted down, again, specifically aligned to physical activity. So Sarah, Rhiannon, really interesting to get both of your thoughts. But what should individuals look out for when they're trying to find a session that is either led by an individual that's had kind of menopause and physical activity training, or something that has been put on to support those that are going through the menopause journey? What should they be looking out for in terms of advertisement of sessions? Is there anything in particular that you would want them to look out for?
That's a really good question, actually. It's tricky because on social media, there are so many different, like, accredited this and accredited that, which is very, very tricky. I mean, as a physio, I would always recommend somebody who has done a POGP course, and you can get some physiotherapy-led sessions. So I would definitely look out for that sort of accreditation. Also, there is a physiotherapy-led course called the Menopause Movement. And that is, have you heard of that? Yeah. And so that is like an accreditation for physios, for pelvic health physios. And again, they've got loads of great resources there. But I wouldn't, in terms of yoga and what other courses there are, I'm going to pass you over to Rhiannon.
Yeah, so it's a little bit similar for us in the yoga world. We have a couple of governing bodies, but we are largely unregulated, actually. So a yoga teacher could do their training, and then they could, choose to work specifically with a particular group. But the big governing bodies really are the International Association of Yoga Therapists and the British Council of Yoga Therapy. And that's if you're looking for a yoga therapist that has a little bit more training in health challenges and specific ways of changing a yoga practice to support an individual's needs. But also the British Wheel of Yoga, they run sessions to train yoga teachers specifically to help people in the menopause. So British Wheel of Yoga is also another one. But if anyone needs a recommendation, I've got a couple of great teachers that work locally, that work specifically with women in the menopause. So yeah, we have a great teacher based in Epping actually as well.
Wonderful. Thank you both. Very, very helpful, because as you alluded to, Sarah, sadly, the social media world can be a little bit challenging to navigate. So actually, it's really important that messages are clear and people find the right activity for them. That leads me on to my final question. It looks like the final question of the webinar. But we may have on the call, similar to yourself, Rhiannon, instructors and groups that are wanting to provide sessions for individuals that are going through the menopause or perimenopause. How can organisations promote that their physical activity can help benefit, support those that are on the menopause? What types of things can they use in their communications or on their posters that really outline the benefits of what you do to support those that go through that life cycle?
I think
Okay.
it's looking at
I'm
the
sorry.
symptoms really, and just trying to align with what actually the individual's experiencing, and then how you can best meet that challenge and best support that person. And I think Sarah and Catherine both spoke a little bit about the mental health piece, but I think that's an enormous part of this puzzle actually. And I think anything that can be relaxation based, alongside all the other work that we need to do for our body to stay strong and healthy, but adding that extra little piece in there I think is really, really important, because often we live in a world where we're so busy. It's almost like when you have a relaxation based practice, whatever that is for you, it doesn't have to be yoga based, but when you're really valuing a person's time to just sit and be still and relax, I think there's so much benefit in that, and it's not something really that is valued all that much in society these days. So yeah, I would say talk about the symptoms and how you can best support people, but trying to include speaking to that person's mental health as well. I think that's really important.
I'm just going
Wonderful.
to jump
Sarah.
on as well. That was a great answer. I would also add to that that we do know, evidence-based, that we need to be doing resistance training and also some weight-bearing exercise to help with that bone density. So again, if you were kind of targeting, kind of thinking about how to use the communication, right, I would use kind of some of the evidence that we've got and say, let's use some resistance training and let's use some weight bearing, as well as some balance work with yoga and that and the relaxation that we need as well. So it's such a combination of everything, but the evidence really does show us that it's resistance training and the weight bearing exercise that are going to be good for our old lady bodies. Yeah.
And that quote in particular, Sarah, the old lady bodies, is absolutely fantastic. I love that.
I cannot claim that. That is definitely not me. That is not me. I accredited that to this woman Lift.
Absolutely.
She's great. But it's a great one, isn't it? It's a good way. It's a good thing to think about. Yeah.
Absolutely. And I think as well, just to kind of tie up the combination, hopefully, of more individuals being aware of the symptoms and actually how physical activity can be of benefit to support the journey and the older them, along with hopefully physical activity organisers and instructors knowing kind of the different benefits that physical activity has. Hopefully that's going to be a nice marrying up of people being more comfortable and more aware that physical activity isn't a hindrance, and it is a huge benefit to support the journey of perimenopause and menopause, which is why we wanted to do this webinar. So that just leads me to say a huge thank you to Rhiannon, Sarah and Dr. Catherine Cole for your time today, for sharing your knowledge, insight, expertise and passion. It's been absolutely fantastic. Great engagement from those that have attended today, so thank you. As shared previously, slide deck and the recording, once jazzed up a little bit, will be available on our Active Essex website. So thank you very much for your time. Enjoy the rest of your day and take care, everyone.
Thank you. Take care. Thanks for organising.
Yeah, thanks for having us.
Bye-bye.
Bye.
Thank you.